Or let's talk about rheumatic fever. It's a consequence of pharyngeal infection with group A beta hemolytic streptococci. Now, to add here is it's a consequence of untreated pharyngeal infection, which commonly affects first children, affects children with group A beta hemolytic streptococci. And rheumatic fever occurs, they're saying late, right? So how late? 2 to 4 weeks after pharyngitis. 2 to 4 weeks after pharyngitis. So a child gets a pharyngitis, sore throat, pharyngeal infection, pharyngitis, sore throat, and somehow the treatment was insufficient, stopped antibiotic, did not even take antibiotic, or there was a resistance to antibiotic, anything, something was there that he left untreated. He was untreated for that as a child. And after 2 to 4 weeks, after pharyngitis, they can go into, it can cause rheumatic fever. So let's read now. It is a late sequelae which includes rheumatic heart disease. Late sequelae of pharyngitis, which affects the heart valves, mitral again. We talked about mitral before, so mitral valve greater than aortic valve. That's exactly what we talk about in infective endocarditis. And then you have tricuspid valve, which is a high pressure valve affected most. Okay, early valvular regurg, late valvular stenosis. So early again, you will have a regurgitation early on, but in late you will have stenosis, and we will talk about that one. It is associated with high yield Aschoff bodies, which are granuloma with giant cells, and Chikhou cells, which are enlarged macrophages with ovoid, wavy, rod-like nucleus. Increase in anti-streptolysin O, which is called ASO, and increase in anti-DNase B titers, high yield. Immune-mediated type 2 hypersensitivity, high yield, not a direct effect of bacteremia. Antibodies to M protein cross-react with the self-antigen, often myosin, molecular mimicry, high yield. Treatment again is treatment or prophylaxis is penicillin. We have a Jones criteria to diagnose it. Let's talk about Jones criteria. In Jones criteria, we have a J for joint for migratory polyarthritis. O for this is sort of a heart shape, so carditis. Carditis mean we have a pancarditis. All layers of the heart are infective. There's infection in all layers of the heart. So pancarditis. And then you have nodules in skin, subcutaneous. Erythema marginatum. And erythema marginatum is evanescent rash with ring margins. So you have a ring, sort of a ring margin, and a rash called erythema marginatum. Okay. Sydenham chorea, which is involuntary irregular movement of the limbs and face. So how do we differentiate this? A patient comes in with rheumatic fever, has some involuntary movements of limbs and face versus Parkinsonism. So let's just do this here. Sydenham chorea versus Parkinsonism. So what is it different? So Sydenham chorea is involuntary irregular movement of the limbs and face, which is called as hyperkinetic extrapyramidal movement disorder. Extrapyramidal movement disorder. While the Parkinsonism is hypokinetic extrapyramidal movement disorder. That's the only difference. Okay. And now let's talk about, so it should have been two major to diagnose it. You must have two major or one minor or two minors. So they haven't mentioned here. I don't know, should I mention that or not? But let's just say, okay, these are the major criterias, okay? And there are some minor criteria, which is simple, which is like just a fever, increase in ESR, and fatigue, which you don't even have to think about. Just remember, fever is one of that, and the major criteria is all the Jones criteria. Okay, now let's talk about some important high yield stuff here, and that is going to be how you have first you are going to get MR or any regurg first, and then stenosis. So let's just talk about the most common here. That in acute rheumatic heart disease, RHD, what's going to happen is you are going to form vegetations. Vegetations on the valve will cause regurgitation, right? And that regurg of which valves are we looking at? We said mitral valve plus minus aortic valve. Mitral valve must. Plus minus aortic valve could happen also. Okay, now after some time, what's going to happen is in chronic RHD, those vegetations will go into scarring, and that scarring will cause stenosis, and that stenosis will give you a fish mouth appearance. And again, the most common valves are going to, the most common things are going to be mitral stenosis greater than aortic stenosis. So what is the mnemonic? The mnemonic for the valves are MAT. Mitral, aortic, tricuspid. MAT. You can use this mnemonic for rheumatic fever. You can also use the mnemonic for infective endocarditis. Except that for tricuspid, you always have to remember Staph aureus, IV drug user, is the cause. And if you see Staph aureus IV drug users, you're not going to think about MAT. You're going to think about tricuspid. Tricuspid is only tricuspid. While the rest of it is always MAT. Okay, that's one of the things. Other than that, let's also take a look at this point, self-antigen. So M protein will cross-react with the self-antigens, which is often in myosin causing molecular mimicry, high yield, right? But on top of that, you have to just know that these self-antigens are not only in the myosin, but also they are going to be in your neuronal tissue. And which neuronal tissue is going to be affected? Basal ganglia. And that is the fact that you have the Sydenham chorea. Okay. And so self-antigens, neuronal tissues, and you have cardiac and joint tissue. So you have M protein cross-react with self-antigens in what tissues? Neuronal, cardiac, and joint. Joint will give you this migratory polyarthritis, and cardiac will give you pancarditis, and everything else is there. Now, high yield is, what is the most common cause of death in these patients? So most common cause of death in these patients is myocarditis. They die due to myocarditis. Okay. Uh, and if because they're causing pancarditis here, pancarditis meaning you have uh, endocarditis, myocarditis, and pericarditis, right? And that pericarditis will give you also friction rub and chest pain, friction rub and plus chest pain because of pericardium getting involved. Okay, that is also important. And endocarditis will give you specific valve problems because endocardium has the valves. So mitral regurg or aortic plus minus aortic regurg. And stenosis will always be seen with the chronic condition, like for example, chronic myocarditis, chronic endocarditis, chronic RHD, long-standing RHD, all of that, right? And this is endemic in developing countries. So immigrant, look for the clue, immigrant. Okay, immigrant. Now, as for associations, is Aschoff bodies, which contains granuloma with joint cells. So Aschoff body is just the name for granuloma with joint cells. And you already know that granuloma would contain a giant cell, right? So that is a good name here called Aschoff bodies. Which is specific for interstitial myocyte granulomas. Interstitial myocyte granuloma. And later on, this granuloma what's gonna happen to this? Later on, this granuloma will be replaced by scar tissue, leading to stenosis of whatever valve it was affecting. Okay. And then this Anetchikau, also high yield, they are enlarged macrophages with a caterpillar enlarged macrophage, the ovoid rod-like. They will also mention it, not only just this thing, but also caterpillar nucleus. Caterpillar nucleus. With the joint cell, one of the cells that you will see is not only macrophages, but you will also see lymphocytes. So which cells, which infective cells, immune cells are going to be seen? Macrophages and lymphocytes will be seen in this disease. Treatment with or prophylaxis with the penicillin would decrease the incidence of acute rheumatic fever and rheumatic heart disease. So this is acute rheumatic fever, and it's a late sequelae of acute rheumatic fever is the rheumatic heart disease. Okay, and that develops after attack usually resolves. So acute attack would usually resolve. So if you have acute attack of rheumatic fever, that would usually resolve. But if repeated infection would cause rheumatic heart disease, which is right here, which would then affect the heart valves, and then would cause all the rest of the things. And that is all for rheumatic fever. Let's review this. Okay, rheumatic fever. Acute rheumatic fever, it's a consequence of pharyngeal infection, most commonly with untreated child infection in childhood, causing pharyngitis in the childhood. that would develop, if untreated, develops acute rheumatic fever. And the bug is group A, high yield group A beta hemolytic streptococci. And then you have late sequelae of that is rheumatic heart disease, which would affect the heart valves, which is MAT. MAT is mitral, aortic, and tricuspid. And then they are associated with two things: Aschoff bodies, which is simple thing. In the myocardium, you have granuloma with macrophages and lymphocytes. And NHCal cells, which are enlarged macrophages again, with ovoid, wavy, rod-shaped nucleus. NHCal cells are the macrophages. High yield is how do you diagnose that? You will have increase in ASO, increase in anti-DNase beta titers. Okay, and this increase in beta titers, it also shows that there's evidence of prior A beta hemolytic infection. Okay, immune mediated diseases is due to the fact that you have molecular mimicry, which causes type 2 hypersensitivity reaction against the self-antigens, which are present in neuronal tissue, which causes Sydenham chorea due to causing effect in basal ganglia, in cardiac tissue causing all of this, and in joints causing polyarthritis, right? With the treatment option available or prophylactic, you're decreasing the incidence of not only acute rheumatic fever, but on top of that, you're also decreasing rheumatic heart disease. The criteria, major and minor criteria, is there to diagnose it, but the major criteria written here is going to be Jones criteria, which is joints, J for joints, migrating polyarthritis, heart for carditis, pancarditis, nodules in the skin, erythema marginatum, and Sydenham chorea. And Sydenham chorea is hyperkinetic versus Parkinsonism, which is hypokinetic, but both are extrapyramidal disorders. With the MAT, they will always cause regurgitation first, acutely, then chronically regurgitation, because of that vegetation doesn't let the valve to close, and that vegetation, when it scars up, it forms stenosis. And that is all for rheumatic fever.